This is a lecture concerning contraindications to manipulation and end-range mobilizations. There are many factors that we need to consider when we think about manipulation, both from the therapist's point of view and from the patient's point of view. From the therapist's point of view, we need to make sure that we have a very thorough subjective assessment. This is extremely important with all of our clients. However, if we're going to be doing end-range manipulation, it's very, very important to make sure that we rule out any type of red flags. We need to make sure that we give enough information and that we are very thorough in our history taking, and that we make sure that the patients totally understand what we're trying to achieve with a manipulation or an end-range mobilization. Consent is very important each time the manipulation or mobilization is performed. At this point, we don't have any written consent that we ask the patient to sign, but we need to make sure that this is written on our charts, that they have consented and we have explained the options to them, both risks and benefits. If we've not completed a sufficient biomechanical examination, this would be a very strong contraindication. This would include making sure that we've scanned, if we're doing spinal manipulation, the joints above and below the area that we're going to manipulate, as well as in the periphery. If we have a physical limitation, that is that the therapist is much smaller and has a large patient, then we're going to be very cautious and perhaps not manipulate that patient and ask for assistance. Lack of confidence in our skills is extremely important, and if we don't have this, then obviously we shouldn't be doing the manipulation. Equipment is very important, and it's almost impossible to do efficient manipulations without up-to-date up and down beds. Incompetence of the therapist is another contraindication. Patient factors obviously include lack of consent, and this is very important. There will be a CAMPed pamphlet produced outlining risks and benefit for the patient, and this should be more information on this will be found on the CAMPed website. Mental status of the patient, obviously if they are disorientated, dementia, that type of thing, not appropriate for thrust techniques or end-range mobilization. People that have an obsession with manipulation, they may have been manipulated many times in the past, and this would be definitely a contraindication. Inability to communicate, we may have to get an interpreter. And if that is not possible, then manipulation should not be considered. Inability of the patient to relax really limits the effectiveness of the manipulation, as well as excessive pain when you're taking them to the end range or doing a pre-manip hold. Patients that are heavily medicated or intoxicated should not be manipulated, and an inappropriate end feel such as bony, empty, or excessive spasm, neurological spasm, would be obvious contraindications. Gross instability, both at the segment that you're wanting to manipulate and the segments above and below. Bony elements, we obviously fractures that are healing. Again, we would pick this up with a good physical examination, and if we have concerns, we would be sending them off for x-rays. Dislocations that are healing, so if they've had any subluxations, that type of thing, this would be a definite contraindication. This is an x-ray of wedge fractures in the lumbar spine, which of course would be a contraindication, certainly while they're healing, and down the road, 8, 10, 12 months, may even persist to be a contraindication because of the amount of pain or muscle spasm. A chance fracture, these are not as common now that we have shoulder straps, but a lap belt, often with a head-on collision, will cause a chance fracture, which will fracture through the vertebral body into the spinous process and transverse process. Bony elements within the spine, such as an active infection seen with osteomyelitis or tuberculosis, congenital anomalies, and gross foraminal or spinal canal encroachment seen on X-ray. Here are some examples of this. You can see that there has been metastases both in the body throughout that low cervical thoracic area. And we know that past history of breast cancer, bronchus, prostate, thyroid, kidney, bowel, and lymphoma can cause secondary metastases into the vertebral bodies in the spine. One common one, or not always that common, but can often come to us complaining of shoulder pain, is a Pancoast tumor in the apex of the lung, and most often seen middle-aged men, and this would be a definite precaution or a contraindication to any type of upper cervical, lower cervical manipulation or first rib manipulation. This is a slide of a malignant melanoma, only seen really after death, would not show up on an X-ray. Tuberculosis in the active infection stage, which would show a fracture through that end plate into the body. Congenital anomalies, as seen in this slide, in the cervical-thoracic region, in the junction there, you can see things where you have asymmetrical cervical ribs. You can have a first rib fused, which would often give you a very abnormal end feel when you're doing your glides. And in C, a cervical rib fused with that first thoracic rib. So again, a very careful biomechanical scan would be appropriate, and then perhaps sending for X-rays. And you may pick up some neurological findings here. Some of the anomalies at the upper cervical area is shown here in the atlas with the incomplete ring. Again, the posterior arch of the atlas incomplete. And the asymmetry of the lateral dimensions of the atlas, which causes the transverse foramen to be quite small, which may again cause some changes to the vertebral artery on that side. A congenital fusion at C2-3. Any type of glide techniques to restore rotation would be contraindicated here. And what we see in the absence of the odontoid, or a very maladeveloped dens odontoid in these 4 slides. Any type of encroachment where there is severe degeneration in the cervical spine would be a contraindication. A lot of osteophytes demonstrated in this area with a lot of narrowing. And the other thing that we would obviously pick up with a thorough history would be her complaint of bilateral pain in both arms. This is again a radiograph of a 52-year-old woman with advanced rheumatoid arthritis, demonstrating erosive changes in those facet joints with a lot of anterior slipping as well. Neurological findings listed here. These are obviously very strong neurological findings that we would rule out any type of end range mobilization or manipulation. Neurological spasticity is obviously something that we all feel when we're doing a pre-manip hold, and certainly if this is a end feel that we're picking up, would be a strong contraindication. Bowel and bladder dysfunction, any of the nystagmus or the 5Ds, the Wallenberg syndrome, and any other kinds of cranial nerve signs and symptoms are contraindications to spinal manipulation. Spinal cord disease or injury, where you see extrasegmental pain below the level of the lesion and it increases with passive neck flexion, is a contraindication. Bilateral, quadrilateral paresthesia, weakness, spasm, hyperreflexia, hyporeflexia below the level of the lesion would all lead us to stop doing any type of end range mobilization or manipulation, as well as ataxia. Cauda equina signs and symptoms, we all remember that the cord ends at L2 and we're looking further down. Signs and symptoms of Cauda equina: hyporeflexia or areflexia with bilateral and or multisegmental, bilateral and or multisegmental paresthesia and pain, positive dural signs, initially bladder hyperactive, increased frequency and urgency, and then paralyzed with overflow incontinence. Fecal retention with impaction and fecal fluid overflow, obvious serious concerns that we would be calling 911 and sending these patients to emergency. Vascular considerations: we will have lengthy discussions about the vertebral artery and whether we can actually diagnose vertebral artery insufficiency, but certainly if they have had a history or any other signs and symptoms that may indicate concern and the problem is coming from a compromise of the vertebral artery, manipulation would not be indicated. Any type of bleeding disorders would be a contraindication. Soft tissue injuries, as these are listed, where we have collagen diseases with poor formation and excessive hypermobility, are obviously not indicated for end range manipulation or mobilizations. These people are going to be more on an education and an exercise for stability program. Marfan syndrome may be a syndrome that you might run across in your clinics. This is a genetic disorder which affects the structure of the fibrils, thereby weakening the connective tissue. It can result in ligamentous instability throughout the body, and it may go undiagnosed from birth. So you may be picking these people up if they've got chronic instability in their ankles, and they've had numerous ankle sprains. Some of the connective tissue that are listed here are obviously concerns that we need to consider. Grisel syndrome is the one that is affected with small children and with throat infections, and the infection will cause an instability of the insertion of the transverse ligament and can cause instability into the upper cervical region. When we think about manipulating either very elderly people or young people, we need to have some thought about what our philosophy is. And obviously, when we're looking at the elderly, it's a matter of looking at the health of the tissue. So we may consider that some people in their 80s would be quite appropriate for manipulation if they're healthy and and have good tissue health. However, some people who are in their 50s or 60s may not appear to be appropriate for manipulation because of their overall appearance and health. Children obviously need to be skeletally sound before they would be manipulated. There needs to be consent from the parent. And at this point in the Canadian Physiotherapy Association and the Orthopedic Division, we do not manipulate children under 14 who have not strong skeletal content at this point. Metabolic diseases such as osteoporosis or Paget's disease are contraindicated, and these are two slides that show Paget's disease as well as the osteoporotic spine, which has the typical fish mouth appearance. Systemic diseases that are listed here would be diabetes and endocrine diseases, cautions, and we would want to make sure we have consent of the patient and they understand the risks and benefits. Pregnancy, certainly within the first 3 months, is a concern, especially if there is any type of history of miscarriages. And in the last trimester, there may be concerns because of instability. And again, consent and understanding the risks and benefits are important. Inflammatory diseases where there are acute inflammations with rheumatoid arthritis or ankylosing spondylitis are obviously contraindications if they're in an acute inflammatory reaction. If they are in a dormant stage, then gliding techniques or traction techniques may be appropriate, given consent and given understanding from the client. An example of rheumatoid arthritis in peripheral joints. And these are x-rays of advanced ankylosing spondylitis, where in this case we obviously would not be manipulating the spine, but would be setting them up on an exercise program and a fitness program. We know that with ankylosing spondylitis, often they come to us with complaints in the sacroiliac joint before any other joints become a problem. There are many medications that we need to think about when we're asking patients their history, and obviously anticoagulants are one. Any medication that affects the collagen, such as tamoxifen and steroids. Medications linked to osteoporosis could be a concern, and antidepressants, just because of the amount of medications patients may be on or their level of awareness. These are the references, and I'm sure that you can find several more. The Modern Manual Therapy Grieve edition, there is a third edition which is an excellent reference to view, as well as your level Theory 1 and 2 manuals.